Hey, what's up, Clint? What's up, Mary Kate?
What's up, Jeff?
How you doing, man?
I'm doing great. How are you?
Yeah, wonderful.
Throwing together some stuff with my kids at the last minute,
Yeah,
trying to get
beautiful.
the house set up.
Awesome. Hey, what's up, you two?
Hey, how are you?
Hey, how are you?
Good. How are you both?
Great.
Good.
Great.
Very good.
Can you hear and see us okay?
We can hear and see you perfectly.
Perfect.
What I'll do is I will share the screen, or I'll share co-host privileges with you. That
Okay.
way you can share your screen, and then we'll kind of get organized as everybody files in.
Perfect.
Love it.
Sounds
Th-
good.
Thank you so much for doing this. We're all looking forward to it.
Oh, thanks for having
Thanks for having
us.
us.
We're excited.
Awesome. Okay. Make co-host should be coming your way here in a second.
Okay.
By the way, I'm Jeff Moore, not Alan Frenendahl. Alan will join us, but I logged in early on his account.
Okay.
Okay, cool.
Sounds like a plan.
Yeah, beautiful. We can see the PowerPoint and we can still see your camera. So that looks great.
Oh, good.
Perfect.
Okay. Okay.
So are you all down in Nashville now?
We are.
We
Yes.
are. Yeah,
We're-
we've been here for 3 months now.
Sweet.
Oh, you know what? Let me, because now I have to let people in.
Wait.
Dan, I can actually sit here and do that for you, I think.
Oh, perfect. Okay.
Don't even worry about that.
Okay. Great. We don't want to leave anyone out.
No, we'll shuttle them all in. And they'll kind of, the way we do it, we have a couple hundred folks in the group. Anywhere between 15 and 50 usually show up. Although I think for this one, you're going to see a lot more than that. Just
Okay.
because it's such a challenge, especially as fitness forward physical therapists, to find physicians who kind of have that same mentality. So I think everyone's just super stoked to hear where you think that's going, and hear about barriers and any ways we can help,
Awesome. Yes, we
love talking about that.
we love time. We need all the help we can get. I think we're only way we're going to get to where we want to go is us all working together, really. So
Awesome.
yeah.
Well, we are certainly ready for marching orders. So looking forward to hearing all of it.
Very cool. Very cool.
What's up, Zach and Alexis? Speaking of Nashville.
Yeah.
What's up, Jeff?
Yeah, what's
Our
up, man?
neighbors over there.
That's
Yeah.
right.
How are you guys?
Doing good. You guys enjoying this perfect weather?
We are. It's
It's
beautiful today.
unreal.
Yeah.
Unreal. November 3rd, right? I mean, wow.
This is the best fall we've had in years, so I feel like you
yeah.
guys are spoiled.
Keep it coming. Keep
Yeah.
it coming.
I know, yeah.
Definitely.
Awesome. We're super pumped. I can't believe we haven't met up yet. I mean, we've been here, what, 3 months? We're gonna have to make that happen.
Yeah.
Yeah, totally.
Help COVID getting in the way.
There you go. Yeah.
Yeah.
I know it. We gotta get you guys to where we can start sending people your way.
Yes,
Yeah.
that will be great. We'll talk about that for sure.
Cool.
Yeah,
Yeah.
that's a big question we all have. I can't wait to hear that part. I know that your licenses are so much different than ours, and with telehealth now, can't wait to see new innovative models where
Yeah.
we don't need to have a ton of people doing the right thing, but if a few are and they have access that's global, we're in business.
Yeah, exactly.
Yeah, for sure.
I mean, we'll dive into. Gosh, I could go on forever on this topic.
Yeah,
It's
love
really
it.
exciting. But we'll talk about it. I want to make
Cool,
sure everyone
cool.
hears it because it's
Awesome.
There's a lot of things that are changing and a lot of exciting movement in the conventional world where people are starting to get it, and that access has always been an issue, but leveraging technology is really going to solve a lot of problems. So we'll dive into that.
Outstanding. So where do you all work out down there? How exactly far outside of the city I know where Zach and Alexis are there in Hendersonville. You're
Yeah.
kind of on the other side, right?
Yeah. We're
Yeah.
on the south side, like probably 10-15 minutes south of downtown.
Sweet. Did you all find a good gym down there? Is there a solid box that you go to down there?
There's a lot. We actually have mainly been working out in our garage and then just dropping into different gyms periodically, which has been really fun. But it's been fun for us to do the garage gym thing and like
Sweet.
Yeah.
very convenient too. So that's
Gives us a good excuse to spend, some resources on a nice garage. So.
That's a clutch excuse.
Yeah.
yeah.
I think Dani ordered half of Rogue.com.
Yeah.
did. I think he did.
And it took an act of Congress to actually get stuff that was in stock.
I was gonna say I knew somebody did. I didn't know who the hell it was, but I guess it was Danny.
Yeah. Yeah, it's like winning the lottery, pretty much. Yeah.
Dude.
Hey, do y'all see the chat box, Julie and Danny? If I type something in?
Yes, we can see it here. Let me pull it up here.
And Julie and Danny, I can pause too. I'll watch that the whole time. So if someone pops up a question and it seems like a good spot, I'll interject. Otherwise, we'll hang on to the questions and fire them at you once we get done.
Okay, that works. That
You're
works.
great.
I've got another screen here, so.
Yeah, I don't want to be like.
Oh, beautiful.
Okay, perfect.
Well, yeah.
Cool.
Jeff, what are you sipping on?
Dude, so I've got it's a nice Pinot. It's from the Willamette. It's from the Willamette Valley. It's dude, it's a cool weather Pinot. It's nice and light. It was perfect for this evening.
There you
So
go. There you go.
most people, when you say that, they think you're just talking complete bullshit, but he actually knows what he's talking about.
Oh, yeah. Big
Yeah.
wine guy.
Right. You
I've
wouldn't
lost,
think
I lost a lot of years selling this shit.
Oh, that's great.
Yeah, he's got some stories, but his wine taste, I don't know, Zach, tell me if I'm wrong here. You know better than I do, but the guy knows what he's talking about.
We've been on the better end of a few bottles in our day.
Awesome.
That's great.
All right.
And they're piling in. So, and Danny and Julie, we'll probably go into maybe 3 minutes after, just to let a bunch of folks who show up on the buzzer be able to hear the beginning, if that's cool.
Sure. Yeah, absolutely. Here, let me turn up the volume here a little bit. There we go. That should be good. Did you guys end up watching the games at all?
Yeah. I mean, I track quite a bit of it. It's just ridiculous. You
It's
know,
just amazing.
I don't know if it's inspiring or if it's demoralizing, but it's a hell of a lot of fun to watch.
All of the above.
Yeah. You got to keep it in perspective. It's kind of like watching, like the FIFA World Cup. It's like, we'll never get there, but it's cool to watch. Yeah.
It was wild. We did CrossFit Hendersonville program, not the online qualifier ones for a week, basically. And so we did them. And man, like, you think the girls are bad. Those things were awful. The end of that week was the worst I've felt since I don't know, a long time. I was like, I'm glad I don't compete at this anymore.
Right. It's like, you have to remember, it's like, well, this is actually, it's not to work out. It's actually a test.
Right.
Make us fitter, you know? Yeah. It's just wild. Amazing what people are able to do it these days and where the sport will be in 10 years. I mean, we look back 10 years ago and we're like, it was like a big deal for someone to lift 505.
Oh yeah.
Now, if you can't rep out 505 for like reps in the middle of a workout while there's 10 other things, like, you don't belong there. It's just crazy.
Yeah.
Yeah, it's mind blowing.
It really
Exciting to
is,
see for us mere mortals.
for sure.
Yeah. Very cool.
Sweet. They're filing in now one after another. So
Very cool.
a couple more minutes.
Okay.
Yeah.
Mark Gallant, looking pretty serious over there, man. You in the middle of a live fish show on those headphones, or are you actually paying attention?
Mixture.
I don't even know what happened. I got no follow-up questions for
It's
that.
kind of like what's going on.
You never tell Mark to unmute that mic unexpected. That can't ever go the right direction.
Julie, Danny, before y'all get started, how'd that Wild Health conference end up going? Was that
Oh,
pretty?
it was really good. It was really good.
It was fascinating.
Yeah, it was just, with these conferences, it's always really interesting to hear some new stuff and new data. But I think the thing that I really enjoy the most is just getting to meet a lot of the other people. And I think from a networking perspective, it's just super exciting to hear, both from like learning new things from other people, but like knowing that you're not the only crazy person on this planet thinking that way. So it was really exciting.
Yeah, they're doing some really cool stuff.
Yeah. Definitely a company to kind of watch over the next couple of years. It's really cool.
Yeah, just straight.
Thanks for posting the link. Yeah.
Yeah, and we'll talk a little bit more about them at the end too, because I'm doing some work with them now.
Go ahead. Dawson, he's something else.
Yeah. They're all like such good people.
Yeah,
Such good people. Operating on a whole other level though, like superhumans.
for sure.
Kind of wild.
And then Danny, Julie, do we have a hard stop on the hour? I'm just trying to think about, make sure I temper the Q&A. How are you all doing on time?
We can go a little over the hour if we need to. Yeah.
Yeah,
We
we're
want to make sure we have plenty of time for Q&A. I don't think, we'll see how long our presentation goes, but it definitely shouldn't take up the whole hour. We should
Okay,
have-
cool.
Yeah.
And we'll be respectful on the back end. We can always keep it to just a few minutes over.
Yeah.
Sweet.
And we're flexible.
Cool.
This is the grassroots stuff that really matters. So we go over, it's all good.
Awesome. Appreciate that. Cool. Well, they're still filing in like crazy, but we're at 30 plus now. I would say we'll go ahead and we'll turn it over to you. And I'll just check in. I'll keep filing folks in. Like I said, I'll keep a track of the chat bar as well. And I'll jump in. So don't worry about following it while you're giving the presentation.
Sure.
And really, without further ado, team, Julie, Danny, everybody here knows you both for a host of reasons. We've got a lot of very avid CrossFitters in this group, so been tracking your stories for a while. But professionally, it really is an obstacle that we encounter. We've built this very fitness forward kind of physical therapy subgroup, of us clinicians who really want to lead from the front in that space and bring people back to health with a very fitness focused mindset. And we struggle because a lot of our folks come from physicians who, they have a good relationship with. And quite honestly, our clinic often has either an ownership relationship with or a financial relationship. And when that physician is saying that, what matters is the imaging and what matters is the medication, it puts us in a spot that we're always digging out of a hole. So I think we looked at folks like you into this movement in general of maybe a brighter next phase, where people don't come with that conception. They come with an idea of like, hey, my doc said I've got to clean my diet up and get in the gym or things are never going to change. Like for us to think about our patients hearing that at the front end is like beyond our wildest dreams. So I think for all those reasons, we're excited for this and I'm going to get out of your way. You go ahead and I'll let you know if anybody has a big question.
Perfect. Yeah. And we want this to be super conversational. So if you find that there's a question that pops us in the chat box that we should answer in the middle of the presentation, just interrupt and we can dive into it.
Yeah. Cool. Well, we're excited. And yes, thank you again for having us. This is one of our favorite things to talk about. And we're going to make it really, we're just going to kind of share our story and our path to how we got to where we are right now, which is really the beginning. Where we are right now is still very much the beginning of our careers, but some of the experiences that have led up to the way that we think about how primary care could be in the future. And then where we're going. And as you'll see, it's not always the most straightforward path, but we're all pointing in the right direction. So it's good to connect with all of you. So bridging the gap between fitness and medicine. So just like you said, does this not go?
There you go.
Okay, so bridging the gap between fitness and medicine. And as you just gave a wonderful introduction about us briefly, both of us are trained in family medicine. I competed in the CrossFit Games. And then currently I'm actually working with Wild Health, a precision medicine practice, and we'll talk more about that at the end.
Yeah. So as Julie mentioned, also family doc. And I work for another medical practice right now called Steady MD, which is a direct primary care practice that's completely online. And we'll talk about what a direct primary care practice is because it's relevant in terms of, I think, addressing a lot of the frustrations that you guys feel from the PT world, but also us physicians as well.
So just in terms of the start of our story, it started for both of us when we were in college, when we met and we both found CrossFit. And that was really the beginning for us starting to think about health in a different way. And at that time, both of us were very much on the path, on the track to applying to medical school. And we started doing CrossFit just for our own health and fitness. Like we both really like to work out and we wanted to improve our general health. And so that's how it started. But obviously things kind of snowballed from there and it became a huge part of our lives through both of us ending up competing and then really getting more involved in CrossFit on other facets as well. So in that early time, even when we were in college, we both did our first CrossFit Level 1 seminar. So I don't know if anybody here has been through the seminar. I highly recommend it. I think it just gives a great overview of the methodology and the purpose behind what we're doing. I think so many people maybe walk into a CrossFit gym, or they do, you know, they see the CrossFit Games on TV, and they think it's all about this super fitness and being really ripped and like just intense and all this stuff. But really at its core, and what CrossFit was when it started, was really about creating health. And this is one of the models that was discussed at the level 1 seminar, which really hit home to me at that particular time as I was getting ready to apply to med school. And it's the sickness, wellness, fitness continuum. So it's this concept of no matter what type of marker you're looking at, whether it's a biomarker, whether it's blood pressure, body fat, whether it's a fitness marker like your mile time or your deadlift or your back squat, you can plot any of those along this continuum, somewhere from a value that would be associated with sick to something that would be associated with well to something that would be very fit. Like we were just talking about these athletes that just competed last weekend in the CrossFit Games. And really our conventional system, really our goal is just getting people well, right? Like if your blood pressure is 120/80, good job, you're doing well. Like there's nothing more for us to do here. But the problem with that is that most people in our society are sitting maybe at well, or probably more so somewhere here between well and sick. And for all of us, no matter what, even if we try our best, something is going to come along and it's going to knock us down in life, whether it's getting in a car accident, whether it's getting sick with, you know, the flu or COVID or anything. Like there are going to be things, stressors that come along. And the more we can build our resilience and the more we can all get all of our markers closer to this fit side of the continuum, the more buffer we have when those things come our way that are inevitable, that we can't predict. And so to me, this really hit home and sort of changed my whole perception of thinking about health and fitness and medicine. And it was sort of in the back of my mind as I started medical school, being extremely naive about the medical system and health and disease in our country.
Yeah, so as Julie mentioned, we started medical school with the best hopes for medicine.
We were very naive, very like classic, like we just want to help people.
Yeah, and that we thought we were going to graduate medical school with the keys to the kingdom of how to reverse all disease, and we could call it a day. We could put up our shingle.
I don't think we were that naive, but we were pretty.
Yeah, we were hoping, all jokes aside, we were hoping that we would be taught on how to actually reverse disease, and what we were really taught, which was still extremely useful, is how to triage disease, and how to treat acute issues like, you know, infections and things of that nature, things that used to kill us 100 years ago. You know, it's very, very important. What it didn't teach us is how to address the elephant in the room, which no longer is really an elephant in the room. I think it's really in the forefront now, is this concept of chronic diseases. And you can see the statistics here are staggering. 6 in 10 adults have chronic disease in the United States, and 4 out of 10 have 2 or more. This is totally mind-blowing, and it's no surprise that it's leading to the bankrupting of our country and the collapse of our economy. I like to think about it almost like slow motion suicide for our country, because really, that's really what's happening, where we're bankrupting it financially. We're bankrupting it from the perspective of people being able to live out the lives that they want to live. So it's no surprise also that 7 out of 10 deaths in the United States are due to chronic diseases because they're so prevalent. And we spend a lot of money addressing this, but we also do a really poor job addressing these diseases. We spend more than anyone, and we have some of the worst outcomes. So we kind of knew that going into medical school, but we were hoping that we would be taught on how to reverse that, and maybe there was something that we were missing. But it became really obvious that the solution is pretty straightforward. A lot of these diseases have lifestyle factors that a lot of people engage in but have a profound impact, such as tobacco use, physical inactivity, and unhealthy diet, and then alcohol abuse in varying forms. So these are the major.
Stress we would add on there from this diagram.
Exactly. So I mean, these are the things that are kind of in front of mind, I think, of conventional medicine. But as Julie just alluded to, there are so many other factors that aren't necessarily addressed in the conventional systems, like stress
or sleep.
Yeah. Exactly, like
relationships.
Yep.
Should all be on here.
Yep. And we're just starting to be able to quantify the effects of those things. There's some really interesting papers coming out that demonstrate that beyond a shadow of a doubt, that those things are perhaps the most important when it comes to reversing these diseases and preventing them in the first place.
And although, you know, a lot of these things are mentioned in guidelines as sort of the first line intervention for a lot of chronic diseases, in reality, because of the system that we have, it just doesn't facilitate a lot of these things happening, because it's the quick 15-minute visit every 6 months was just really just not the best place to be able to help people make these more difficult lifestyle changes. And this really became apparent to us, I would say, in our first couple years in med school. So we both went to the same med school at Cleveland Clinic, and during our first 2 years, we had a half day a week in a primary care clinic, which was where we were learning our basic physical skills and history taking skills. And it just became very apparent to us that we would go and we'd see patients there, and we'd talk to them, you know, maybe someone had high blood pressure or some diabetes, or they were overweight. And we talked to them about changing their diet or exercising or maybe sleep or other factors. And then we wouldn't see them for 6 months. They'd come back 6 months later. And of course, we'd be having the same conversation, or maybe have to increase their medications. And it just felt like you're banging your head against the wall, like you're not really able to make a real difference for these people. And it was such a contrast for us, because then we were spending all of our evenings and weekends in the CrossFit affiliate. And, you know, we were very embedded in the CrossFit community, and there we were seeing people really dramatically transform their lives and their health. They were losing weight, they were gaining confidence, they were coming off of medications. Things were happening there that we had never seen happen in the doctor's office. And it just became so clear to us that, you know, this doctor's office 15-minute visit is not the place to be able to help people make the actual changes that are going to have the biggest impact on our health. So that was kind of always in the back of our mind of, okay, this isn't really the right way to be administering the type of care that we want to in order to have an impact on health and people's quality of life. So this was just one example. Obviously, there's a million anecdotes, but this is Pete Katz, who I've interviewed on my podcast before, and he's given me permission to share his story in presentations like this. And I met him when I was in med school. He was seeing one of the faculty that I was working with. It was his primary care doctor. And I went in and saw him one day, and he had a very typical story. So he, you know, in his 20s, when he was in college, he was really into triathlons. He liked to exercise, he was active, but then just kind of work became busy, started a family, kids, lots of stresses, and just started to gradually gain weight and gradually start to accumulate these chronic disease diagnoses and medications. So when I had met him, well, before I had met him, he had been diagnosed with type 2 diabetes. He was on 2 different drugs for that. He had been diagnosed with hypertension on 2 different drugs, hyperlipidemia, fatty liver, anxiety, and sleep apnea. And he had tried a bunch of different things. You know, he had tried a lot of different diets. He had tried to get back into swimming. He had gone vegetarian for a while. He would go through different spurts and phases where maybe he'd make a little bit of progress, but then he would kind of fall back into his old habits. And it was really frustrating for him. But eventually he found paleo. He started doing a paleo diet, and he joined a CrossFit gym. And for him, it was completely life-changing. And now it's, I think, 7 or 8 years later, he's been able to sustain all of the changes. And in large part, he really credits the CrossFit community for being able to do that and being able to do that over the long term, as opposed to a lot of the other diets or things he had tried. So this is a picture of him more recently in the CrossFit gym.
Look at that good overhead position.
I know, right? And here's some of his numbers. So when he started out, his A1C was 11.4. Now it's 5.1. And I think even more recently, it was even lower than that. He's off all of his meds, all his hypertension meds. His cholesterol made a dramatic improvement. Doesn't have fatty liver anymore. No medication for anxiety. He's lost, I think, at least 75 pounds by now. And the numbers he's most proud of course, are all his performance numbers. So now he can deadlift and front squat and back squat, and he learned how to do pull-ups and rope climbs. And those are the things he's really proud of. And he's really become such a role model for other people in the gym too. Just seeing his transformation really motivates the people around him. And so this for us is really just a perfect example of what this is all about. And how the impact of, you know, how many visits he had had with his doctor over the years, talking to him about these things, and how many interventions he had tried, but nothing really stuck until he finally had something that he really enjoyed doing, something that he was really passionate about, and he had a community of people around him that encouraged him and kind of helped hold him accountable. So this was all happening during our first couple of years of med school, and we knew there were some things that we knew to be true. Like we knew, okay, this system is not the best place for us to administer the type of care that people need to really be able to get better and promote health. We knew that CrossFit provided some sort of a better place, but we also didn't have a great framework for how to provide really good care that promotes health. Like we knew a lot of things were important. We knew sleep and exercise and stress management and relationships were all important, but we didn't know how to put it all together. And then when we finally heard about functional medicine, that's kind of where things started to make a lot more sense to us.
Yes, exactly. So I'll give you guys kind of a crash course in what functional medicine means, because there are a lot of different ways that people interpret this term, and we'll kind of talk about it, how it's presented or discussed in the context of really by the Institute for Functional Medicine, which is kind of the biggest academic body for functional medicine. So let's contrast kind of conventional medicine, the conventional medicine approach to the functional medicine approach. The conventional medicine approach we'll look at a set of labs, look for a pattern essentially. Both approaches will look for a pattern, but conventional medicine will look for a pattern and then try to assign a diagnosis. And there's thousands of diagnoses that have some sort of treatment associated with them. So it's this idea of name them and tame them, that kind of thing. And the approach is really to get the biomarkers, the things that we used to assess if the disease is present, back in check. You can think of, or the symptoms.
Yeah.
You can think about it like your cholesterol numbers or depression. You know, we want to quell that with some sort of intervention. The focus isn't necessarily about reversing the cause more with chronic conditions. Certainly that's the approach if you're treating an infection. But generally speaking, it's all about kind of treating the symptom or the dysfunction versus actually getting to the root cause.
Mm-hmm.
Now, functional medicine is totally different. It kind of has a bottom-up approach. You can see here in this tree, you can see different specialties listed. So you see all the different common specialties, neurology, immunology, and you see signs and symptoms below that. So, you know, all these specialties are trying to address the signs and symptoms here. But signs and symptoms are exactly that. They are a clue to some underlying process. And if we only go that deep, we're never getting to the root cause. And what even the conventional literature is starting to show is that the root cause for a lot of these dysfunctions are actually lifestyle related. So sleep, stress related, nutrition related. You know, we're learning the power and the importance of relationships now more than ever with COVID, people getting depressed, seeing manifestations, worsening of their autoimmune conditions just by being isolated. All these things are actually the things that make us healthy and keep us from getting sick. And all those things are actually filtered through our genes, because that's kind of the hardware of our body. And these lifestyle factors filter through our genes and then manifest as symptoms. And a really important point here is that different imbalances or dysfunctions or exposures can manifest as many different diseases. So somebody may have, you know, everyone's familiar with celiac disease. Some people may manifest as having diarrhea or bloody diarrhea or some variation there. Some people may simply have a rash. Others may be depressed. Others may have neurologic symptoms. They all come from one fundamental root cause. But by addressing that root cause, you can reverse all those different conditions. Pete Katz is another great example, right? He had diabetes, he had hypertension, he had hyperlipidemia. What was the problem? It was the lack of movement and the improper fuel, right? The root cause manifested as so many different things.
Mm-hmm. And in a more conventional sense, if you don't find that root cause, you end up on multiple different treatments for all the symptoms. So in the example Dani just gave with celiac disease, maybe someone they have a rash, so they say, okay, I need to go to a dermatologist, and they get a cream or some sort of treatment for it. Or, you know, they have diarrhea, so they get diagnosed with IBS and they get medications for that. Or maybe they have multiple of these things, they're on multiple medications. But if we could just identify a root cause, it's not always that simple that it's just, oh, you're, you know, allergic to gluten. But if we can identify the root cause, then we can get rid of it, you know, from that standpoint, instead of constantly chasing all these different symptoms.
And the other fundamental piece of how functional medicine is different from conventional medicine is that conventional medicine is very siloed. We look at the cardiovascular symptom in isolation. We look at the immunologic system in isolation, the nervous system in isolation. Functional medicine understands that all those work together. And I argue that all medicine really understands that, but the focus is different. Functional medicine looks more at function. You can see here the fundamental organizing systems and core clinical imbalances. These are things like assimilation, defense, repair, energy, and so on. These are fundamental processes that the body needs to manifest to keep in check, to keep operating in order to live. And there's a mixture, a coordination of all the different organ systems to accomplish those tasks. And when you have that understanding, it makes medicine more fun and a little bit more complicated, I argue, but you really understand of how, really the nature of reality, of how the body actually functions. And that's the frame that functional medicine uses. It uses the understanding that it's our exposures filtered through our genes that affect our function, that then manifest as signs and symptoms and eventually diagnoses. So the diagnosis is really the beginning of the whole journey. It's not the end.
Mm-hmm. And we sort of stumbled upon this because we were in the middle of med school, and we had gone to a talk that was hosted at Cleveland Clinic for wellness grand rounds, and didn't really know what to expect, but Mark Hyman was speaking, and I had heard the term functional medicine before. And so I was like, oh, well, we'll go to the talk and figure out what it is. But it turns out that's the talk where they were announcing that they were opening the Cleveland Clinic's Center for Functional Medicine, which was the first sort of functional medicine practice in a big academic center. And we were just lucky to kind of be in the right place at the right time to be able to learn more about this when we did, and really realize that, okay, this is the operating system we were looking for in order to start to make sense of a lot of these things and figure out what sort of lens we wanted to practice medicine through.
Funny side story, it was actually around that time when I was almost dropping out of medical school and was about to open up a CrossFit gym because I was so disillusioned with what I was learning. I was like, I went to medical school to learn how to heal people. This is not happening. So this brought me back and put me back on the straight and narrow.
Yeah. And speaking of that, that's sort of when we both decided to go into family medicine as our specialty. So I had actually decided much earlier, it was very clear to me, but Dani took a little while before when he was going to go open a CrossFit gym, then he was going to be a surgeon, and then he was going to do ENT.
It took some time.
It took some time, but he came around, and we both decided in the end, once we looked at this and we saw how much, we really wanted to be able to help people from the prevention side, from the front end, and we wanted to be able to develop relationships with people over the long term. And for us, family medicine just made so much sense because of how it really focuses on the whole person. It just made the most sense for us as far as our training. And so we both did residency in family medicine at Cleveland Clinic as well. So this was just a picture of us when we were both there. There was 1 year where we overlapped, we were both there at the same time. So family medicine. But while we were there, we also were very much in the weeds of how broken our current system is in order to deliver good primary care. So we know a lot of things, and this is not news to anyone here, but in conventional primary care, because of the way the payment structure is, each primary care physician has to have somewhere around 2,000, sometimes more than that, patients on their panel in order to sort of make ends meet. The visits are short because you have to see so many patients a day in order to get the reimbursements for those visits and keep the doors open. As we just talked about, it's very reactive. So again, it's waiting around until someone gets sick enough to want to come to the doctor. And then when they come, putting the symptoms that they're having into some sort of diagnosis and providing whatever treatment it is, it's going to get rid of those symptoms, as opposed to looking at a person and saying, how can we make you as healthy and function as optimally as possible? It's expensive for everybody involved. Insurance is expensive. The cost of healthcare is expensive. As Dani said, it's bankrupting our whole country. It's impersonal. It's something that I think both doctors and patients feel when you're rushed in through this clinic and you get 15 minutes with someone and you don't have time to talk there. You don't really feel like you can build a real relationship or any sort of trust. And I know that it's something that is difficult for doctors, and it's definitely difficult for patients. And because of that, there's really high burnout for physicians in primary care, and there's a lot of dissatisfaction from patients. For us, I think it's one of the most frustrating things to see our colleagues, especially in family medicine, who go into it for all the right reasons. They're not going into it because of the money. They're really doing it just because they want to help people and be there for people through, their ups and downs and help them with their health. And they go in, even in residency, I've seen that over the course of the 3 years of residency, someone coming in just so excited and hopeful, and then realizing how much the system is just going to crush them. And it's really unfortunate. The payment incentives are misaligned, so you get reimbursed to bring people into the office as often as possible instead of to keep people really healthy. There's really no price transparency, so patients are frustrated because you're paying $1 bajillion for insurance, and then you're getting these huge bills for labs or office visits or surprise fees that you don't even know about, which is extremely frustrating. Again, it's focused on suppressing symptoms, and the care is really episodic, again, because people avoid coming to the doctor unless they really need to because it's expensive. So you end up not being able to see people on a regular basis or really work on the underlying causes, it falls into that more reactive category.
And the other thing that happens that I don't think is mentioned a lot is it really robs people of hope, in that the standard is set up that once you get a chronic disease, you're forever going to have that chronic disease, and you're going to be at the mercy of the medical system and of medication, which I think is that is just so potent and kind of something that we saw in clinic all the time. You know, people saying things like, "Oh, my dad had diabetes, so I'm just going to get diabetes." People were no longer surprised that you gave them the diagnosis of diabetes. They thought it was kind of determined for them in the future. So it kind of, without noting that people are, you know, you're robbing them of hope, which I think is probably the biggest, the most egregious thing that medicine is doing, even more. You know, what's worse than robbing hope?
So knowing all these problems with our conventional system, again, we were sort of disillusioned, like, how are we going to be able to do this? But luckily, in our program, which was very progressive and exposed us to a lot of different models, and we started to learn about this model called direct primary care. And so this is us at a direct primary care conference. We spent a lot of time learning about this during residency, and there's a whole amazing community of direct primary care doctors across the country that share the same frustrations and have found a better way to practice. So
yeah, so we'll give you kind of the book definition of what direct primary care is, and then we'll really talk about what it's like on the ground. So direct primary care is a model of delivering care. In a way, it's a way of structuring payment and delivering services. So in this model, you charge a periodic fee, usually in the form of a monthly fee, to be a part of this practice. What makes it very different from concierge medicine, because people typically get direct primary care and concierge confused, is that it doesn't bill insurance or any third party. You're totally outside of concierge. Concierge bills both the patient from a membership fee perspective, and then also bills insurance, kind of this concept of double dipping, if you will. So we, as direct primary care providers, do not do that at all. And it actually affords a lot of advantages, which we'll talk about in a second here. And then there's a technicality where the per visit fee charge can't be less than the monthly equivalent of a periodic fee.
yeah, and you know, a per visit fee is it's optional. Like, so some practices have them, some don't. There's obviously a lot of different ways to do this.
Yeah. So the way it works out, what it actually looks like is that, as I mentioned, patients pay a membership fee, and it's not terribly high. Most of the time, actually, if you have a direct primary care, if you're a direct primary care member and then have a higher deductible insurance plan, it's much cheaper than having traditional medical insurance. And most people are honestly transitioning to higher deductible plans because, you know, these other plans are virtually unaffordable. The average cost is about $82 per month. That certainly ranges from anywhere from, you know, $50 to $70 to sometimes even $150 per month, depending on what services are offered and the community that you're practicing in. As I mentioned, there's no insurance billing. And what that allows these practices to do is they're no longer held hostage to the reimbursement that the insurance is willing to provide. So the way we typically see this playing out is if we order labs, they may, you know, traditional labs, say complete blood counts, some liver markers, things like kind of annual screening labs. If the patient's insurance plan doesn't want to pay for that, the patient may get a bill of $300–400, right? How often has that happened? I think that's happened to us as well. We have great insurance. However, if we function outside of the system, because of the word direct primary care practice, we can have direct relationships with labs. Those labs can cost $15. And this is not an exaggeration. It can go from $300 to $15. And we see this all the time. The same phenomenon happens with medicines. Because we're not in the system, we can negotiate directly with medication suppliers, distributors rather. So you can get medicines that are, you know, $300–400 for like $50 a month. It's mind-boggling how much these things are marked up. So by having this combination of having access to cheaper therapies, if you will, you actually end up spending less money, even though you're enrolled in something that requires you to pay every single month. And because you have from a practice perspective, because the practice has guaranteed income in the nature, in the form of the monthly membership, there's less volume that you need to see to keep the lights on. So you have smaller patient panel sizes, which then translates to longer visits and better care and better relationships. And because you're not tied to insurance companies either, now you can actually provide care which is just which makes sense for the patient. You don't have to bring them to the office. You can do a phone call. You can do a text message. You can do a video visit. You no longer have to be held hostage to bring people into the office just so you can get paid. And then obviously all this stuff, you know less people, you have longer visits, you develop these really profound relationships, which again, the data is showing that it's profoundly therapeutic to have a good relationship with your physician. Now all the incentives are aligned, everyone's on the same page. My sole purpose, our sole purpose is to get people out of the office, to be able to do the things that they want to do, to get them as healthy as possible. And the beauty of this is that it's affordable for most people. And I know there's probably some of you thinking, because I had the same thought, that there's no way this could work in a low socioeconomic community. There are ways of tweaking this so it actually does work in lower income areas. And then additionally, it's also transparent. You know exactly what you're paying for. You know the membership, you know how much medicines cost.
Dani, two things. First of all, for me, this makes way the hell too much sense to work. So I think we got to scrap this. But
Yeah.
second of all, Martha had a great question. Do you need to have a special pharmacology license to negotiate that medication part? Or is that an all play that any MD could do that? Or how does that work?
That's a really great question. And it's state dependent. Most states, I would say that maybe there's like 5 or 10 states where either you cannot do that as a medical provider, or you have to get a pharmacy license, or it's like a certificate. You don't have to be a pharmacologist. You just have to let them know what you're doing, that you're not doing anything shady. You're not a pill mill or anything like that. You're doing the right thing. There are some states where that's not the case. dpcfrontier.com is a great website where you can actually look state by state what the laws are, specifically for distributing medications in the office. Mm-hmm. It's a great website, actually, just in general, if you're interested in getting into the space.
Mm-hmm. And then there are some great suppliers for medications that you can just order them in bulk. Mm-hmm. If you have one of these types of practices and if you want to actually dispense them. And there's specific laws state by state about dispensing medications in your office.
Yeah. But most, it's really remarkable that no one has done this earlier.
Well, they did. We're late to the party, but people have been doing it. But it hasn't been that long.
Yeah.
It has not.
Is it frozen? I think you got to click on it again.
Oh, there you go. So yeah, it hasn't been that long, because this is kind of a map of how these direct primary care practices have been exploding over the past 6 or so years. Back in 2014, there was less than 200 practices. And today I think there's somewhere close to 1,400 around the US. So it's still very new, but the growth has really been just taking more of an exponential curve, really because so many people are just fed up with the system, doctors and patients alike. And we've seen it already. I mean, in our residency program, there were a couple, years ahead of us that had gone into DPC since we, in the past year, a couple of residents that you did residency with have switched over. They worked in the conventional system for a couple of years and they said, nope, I can't do this anymore. They're switching over. And now when we brought in our first new class of interns our next class of interns this past July, already half of the class already said they wanted to do direct primary care when they graduated. So it's like this next generation of primary care doctors coming up gets it. And they're not going to put up with having to practice in this way that isn't consistent with their values or the type of care they want to provide. So
sure.
A lot of growth.
Right. Oh, I almost forgot what I was going to say, but I wanted to quickly chime in here because I think it's appropriate given the day-to-day election day. This is probably one of the few things that both Republicans and Democrats can agree upon, which is amazing. We've heard from both sides of the aisle bills being passed to really clarify what direct primary care is. And this might be a small nuance, but I think it's worth mentioning here, because direct primary care charges a monthly fee for services that haven't necessarily been rendered yet, because theoretically, if you're paying for something you haven't gotten it yet, or you haven't gone to see that doctor, that could be interpreted as insurance by some individuals, by the insurance commissioner in each state. So now all of a sudden, some of these practices may be thought to be an insurance company, which is a nightmare, right? So there is lots of legislation in place in the states where this hasn't been clarified yet, and there's really good laws actually in Tennessee, which is one of the reasons why we moved here, that clearly define direct primary care as not insurance. And this is just, I mentioned this only as an example of there being kind of bipartisan support for this, to really clarify the role of direct primary care in the future, because it's pretty clear that it's a very cost-effective way to solve the healthcare crisis, or at least part of the solution.
And there's also legislature around, you know, people being able to use their HSA dollars or FSA dollars to pay these membership fees, which is still a little bit fuzzy, but I know that that's something that's, you know, this is also new. And I think we're hopefully going to see more and more legislation that just continues to support and protect this model.
Very cool. And then question, how do you negotiate things like all the imaging, the MRI, the X-ray, the labs? Do you
Yeah.
find one place? How does that work out?
Yeah, it's actually surprisingly simple because, you know, it's mind blowing how much these companies actually spend chasing dollars down, and how they have to hire a person just to hassle the insurance company to get the money that they really should be getting by contract. They sign a contract when they negotiate these insurance contracts. Really what it entails. So for medicines, they're distributors where literally you just show your medical license, you fill out a profile. That's very easy. With imaging centers, you just call them up and tell them, hey, this is what I'm looking for. They negotiate a rate with you. Usually it's very, very cheap, on the order of getting MRIs for like $300. It's ridiculous.
Yeah,
it's crazy cheap. And then, you know, for different specialists, because this is commonly a question, like let's say I have a high deductible plan, I need to see a cardiologist. Even specialists are open to cash prices, like a pre-negotiated cash price. So everyone's very excited about this because they know they're getting paid with minimal hassle on their end.
Yeah. And there's services too. I'm blanking on the name, but I know there's services where you can that will help you find imaging centers in your area, and we'll compare like, here's the imaging centers in your area and the cash prices for them. So it's easy for you to navigate.
It's kind of like we're still in the infancy of this whole thing. I think eventually there's going to be companies that perfect this, build these ecosystems. That, you know, there are a couple actually where we used to live in Cleveland. There was a company, actually there might be national, Paladina Health.
Yeah, they're all.
Which is a direct primary care practice that has built out of amazing infrastructure. So there are, you know, to answer the original question, you kind of just talk to people.
Yeah, but it's I mean, there is a really great community around it and people that are so willing to help out, which is awesome. So we've been learning about direct primary care, and then a lot of this sort of came full circle for us too in the past couple of years with what we had started with in CrossFit, which is more for competitive and for our own health, but then really seeing CrossFit take more of a focus on health. And so the past couple of years, we had both been involved in these CrossFit Level 1 seminars, the same one that we did, you know, when we first started and learned about the sickness, wellness, fitness continuum. Now have been going back and teaching those for other physicians and really trying to help more people understand that CrossFit is about much more than just fitness. It's about the underlying health. And they've done also, this is probably a little known fact, and have accumulated a ton of amazing content, really incredible speakers, and actually have a whole CME platform now where you can get CME credits on their website. And there's actually a directory now, it's still being built, but where you can find physicians in your area who do CrossFit, and you can sort by specialty if there's someone that you're looking for in particular. So this is all still very new and evolving. So we know there's been a lot of changes for CrossFit in the last year, specifically in the last few months. And we are both very hopeful and very excited that health is going to continue to be a very strong focus for CrossFit, and the ways that we may be able to continue to kind of work together to make that happen. So we're very hopeful about where it's going. But really, this is kind of what sums it up. This is where we really see the future of good primary care and, you know, really health promoting primary care. It's the overlap, this sort of sweet spot between functional medicine, which is getting to the root cause of the symptoms, direct primary care, which is this payment model or this model of practicing care where all the incentives are aligned, where you can facilitate having a relationship with the patient, where you can actually work on these underlying causes. And then CrossFit as one example, but an example of a community-based program where people are actually going to be able to implement these changes in their day-to-day lives, where they're going to a place or with people multiple times a week. So they're going to be able to make sustainable lifestyle changes and have a community that supports them and holds them accountable to them too. So this is really where we see our sweet spot. And we had, you know, like I said, it's been a windy path. So we had full plans to actually have a clinic open in Nashville by this time this year, but COVID and then a few other things have slowed our plans down a little bit, and a few other like very exciting opportunities, which we think are worth waiting for to sort of pan out before we jive in full speed ahead. So we fully anticipated when we agreed to do this talk that we would have a place for you all to send your patients right now, but we don't quite yet, but we definitely will in the future. And for right now, we can tell you a little bit about what we're doing right now, because I think both of these are great places to send patients as well.
Yeah, so I've been working for this company, SteadyMD, for the last 3 years. And as I alluded to in the beginning, it's a direct primary care practice, meaning it's consistent with the model that we were talking about over the last couple minutes, but it's totally virtual. We have doctors in every single state with licenses in every single state. What makes this really exciting is that it really tries to get the relationship back in medicine. That's kind of their focus. They have doctors, greater than 30 doctors really, with different interests, obviously, and they try to pair you with a physician that has similar interests. So I'm obviously super passionate about CrossFit, fitness in general, and I have a lot of patients that do that. And as a result, I kind of developed a familiarity and kind of a comfort with that patient population. There are docs who are power lifters, triathletes, people who don't work out, they just like paleo, or they are vegan and they want a doctor who's vegan also. That's kind of the beauty of this platform. So I see patients through that virtually. And I have licenses in about, I think, 19 states now, which covers most of the United States and the most populous areas for sure. But that's where you can find me for the time being until we figure out what the next stage of our adventure is.
And then for me, this is what Dustin was just and I were just talking about, is I started working with a practice called Wild Health, which is based in Lexington, Kentucky, and also in Bend, Oregon. And they do a lot virtually as well, but it is a precision medicine based practice. So kind of thinking back to that functional medicine tree that Dani was talking us through, you have your roots of your lifestyle factors, but it really all filters through your genes and how your genes interact with your environment. And so they really do an amazing job of first starting with the genes and looking at what makes you you, what makes you sort of unique, and then really diving into those lifestyle factors and saying, seeing what your lifestyle factors are and how maybe we could slightly tweak those lifestyle factors in order to make you more optimal, healthier, better able to achieve whatever goals it is that you have. And then always looking at that also through the lens of biomarkers, other data that's giving us some sort of compass as to, are we moving in the right direction or are we moving further away? So it's a lot of exciting stuff that we're doing there. And they also have a fellowship program. They're working on training other doctors and health coaches in terms of how to practice this type of medicine. So this is another, I think, great place. They're very fitness focused for sure. A lot of their health coaches have various expertise in different areas of fitness, or exercise science, physical therapy. I think, do they have physical therapists? And so definitely a very fitness forward place to send patients as well. So that's pretty much all we have. That's kind of our story where we're at, and we will definitely would love to keep the conversation going and keep you guys updated as we evolve into the next phase. But we would love to answer any questions or any other discussion. I see there's maybe a couple popping in here on the chat box.
Yeah, totally. One off the top is, Dan, you mentioned 19 states. How does it work with MDs? I was under the impression that they were licensed across the country without the same limitations of state barriers. Is it relatively easy for you all to grab licenses in all the states and you're just grabbing the most populous ones, or what are the barriers there, if any?
Yeah, great question. And it's definitely changed in the last 6 months quite a bit. So pre-COVID, what had to happen was that you took one medical exam, you get boarded by, the American Academy of Family Physicians. You got your check mark that you know medicine. And then you would apply for each state to practice medicine there. Now, it didn't require an additional exam, but you had to fill out an application. And of course, everyone wants their dollars. So you had to pay, a fee as well, which can be as much as $450 per state.
Okay.
So now, even actually, I should admit, even prior to COVID, there were certain states that were forming these pacts where you get licensed in one, and then the licensing process was accelerated, but you still had to usually pay that fee. Now, given COVID, kind of it's still state dependent to some degree, but the general trend is kind of like all bets are off. Just take care of people, F all the rules. Like, we just need to get this thing under control. To the point where now, like, a lot of the privacy regulations, like, For example, it used to be that everything had to be encrypted. Now people are like, just text Grandma Jane, just make sure she's okay. Who cares if it's through FaceTime kind of thing? Like, that's kind of where we're at right now. It'll be very interesting to see what happens in the next year when kind of COVID is more under control. We may see a return to kind of the previous status quo where license by license, you have to get state by state licenses. I imagine that it probably will be somewhere in between.
And the big thing that makes it difficult is in order to establish care, you have to be in the state. So like say we had a license in Tennessee, if someone comes and sees us in Tennessee and we establish care there, then we're good. We can follow up with them wherever they are. But like what Dani's platform on SteadyMD, because he's seeing people all virtually, he has to have a lot of licenses in order to be able to establish care with people in different states.
So if you're establishing care virtually, you have to have a license in the state where the patient resides. If they come and see you in the form of medical tourism, then they can go back to their respective state and you can follow up with them.
Okay.
Yeah.
So I've got to ask, and by all means, if the answer is, Jeff, we got to keep that close to the vest. I understand that. But I'm dying to know, what does the 3 to 5 year national takeover look like? Is there a plan of like, if everything scaled the way that you've always dreamed of, it would look like X, is there any insight you can share into what that might look like as far as what you're trying to do mission wise?
Yeah, I mean, I think for us, like this model of being able to have like a direct primary care practice where you are able to practice root cause medicine through functional medicine, but where you have places to send your patients. So like I imagine our practice, for example, at Nashville being an example, we have our small practice, but we can serve patients through Nashville, and our patients also have a place like a CrossFit gym where they can go to be able to implement these things. So whether it's working with the trainers in the CrossFit gym to develop a more well-rounded understanding of health and how to help do health coaching beyond just fitness, but we're talking with them about sleep and stress and nutrition, all those other things where they're going to be able to get all the things that they need to optimize their health and their lifestyle factors in that environment where they're spending most of their time, but where we then have an open dialogue and an open relationship with their health coach or their trainer and with the patient for whenever something comes up, or on a yearly or even more frequent basis of really taking a look at labs and biomarkers and seeing how we can optimize further. So that's kind of how we see it. And we would love to be able to do that, not just in Nashville, but everywhere. That would be the big
we want it to be, kind of a framework that other doctors can take and run with, and they can iterate on. Because the thing is, the demand is overwhelming for this kind of medicine, both from a patient perspective, but a physician perspective too. People want to practice this kind of medicine. What makes it really challenging right now is that, a lot of people are strapped with a lot of debt. And it's really risky to all of a sudden open up your doors. People forget that, when you're opening a practice, you might have 10 patients the first month, 20 patients the next month, and you're used to getting a salary. You need to have a lot of buffer to kind of make that leap. So part of kind of our vision is to make it scalable, but then also offer opportunities so people can feel comfortable jumping ship from the conventional system.
Exactly.
Cool. Anybody else want to mic up? Feel free to jump on. I think we'll be all right. Yeah. Zach, go ahead.
I think somebody had a question about the DPC website. It's DPC Frontier is the website. Yeah.
Oh, this one. People seem so pessimistic about exercising and eating well, worried about injuries, not enough time. How do you change the script with them?
You can send them our podcast we recorded last week.
Yeah, we did last week a podcast about CrossFit injuries, but which I'm sure you guys know way more about that than we do.
I'm sure.
It was our general kind of spiel that we give people, but I think it really comes down to, in terms of motivating people, in terms of behavior change, it comes down to really finding out what's important to the person. And, it's hard. All these things are hard if they're not part of your routine and they're different than your normal habits. And so being able to, that's why the relationship is so important, because being able to actually help identify what's most important to this person and what's going to motivate them, and how can you anchor some of these changes to show them how it could make their life better in the ways that they really want it to be. There is a fantastic book that we both read in residency that we love. It's called How Healing Works by Wayne Jonas. And he has a fantastic model of just thinking about that. How do you how do you connect what you're doing to what's most important to that person? Because otherwise you're never going to get anywhere.
Yeah. That book also does a really nice job of focusing on the things that actually create health, which is those
Yeah.
lifestyle factors that we talk about quite a bit.
Yeah, he talks about, I think 80% of health is created outside.
It has like
medicine.
nothing to do with medicine.
Nothing to do with medicine.
Yeah.
Which we all know, but.
It's like, yeah.
I saw Jamie Chateau asked him, how does DPC work with specialist visits outside of family or internal when it kind of comes to that?
Yeah, so people typically fall into two different camps. One, they have insurance and they want to use their insurance to see their specialist there. It's pretty straightforward. You know, they kind of use their insurance. If they have insurance and they don't want to use it, or they don't have insurance, that's the second group. Usually what direct primary care practices will do is they'll negotiate a rate with a specialist in their area. So it would be like you call up, you know, the cardiologist down the street and say, you know, can you see this patient for $100? Does that cover a 30-minute visit? And then the patient, you know, knows that they're going to get exactly that. And then oftentimes you can also negotiate tests. Let's say that somebody has chest pain, needs a stress test. You can negotiate procedural kind of rates as well with a lot of specialist office. Allergy testing, super common, right? You can negotiate rates for that as well. Again, people are super open to doing that because they know they don't have to chase the money down.
Yeah, and then there's also cool resources like you've been in the past have used something called Rubicon MD, which is basically like an e-consult service where there are specialists that you know, as a physician you can use and just run the case by them and get some feedback.
It's like a curbside almost.
Yeah, it's like a curbside. So it's not, you know, it doesn't cover you from like a legal perspective if you need someone to see a specialist because they haven't seen the patient themselves, but a lot of times it can help direct a further workup or get you a little bit further before they actually have to see someone or pay, you know, if it's going to be expensive for them to pay.
And also I think from a learning perspective, because sometimes, you know, physicians get really siloed and they practice their one way, and they, you know, it's hard sometimes to learn when you have a pretty busy practice. Rubicon MD, I use it a lot for education too. And I'm like, this is weird. Like, I've never seen this before. Am I missing something? You can use services like that to just run cases by people. So we're not sponsored by them or anything, but we just love it. We just love it.
That's awesome. Lindsay asked, are you considering partnering and staffing like specific boxes, being in-house at each box? You know, we hear about this all the time, this doc in a box idea. Like people say, no, there's doctors out there, like they're unicorns. You know, they really love this stuff. Are you looking at that model at all down the road?
So we like the idea of the doc in the box, but we also feel like I don't see the model working in terms of like one doctor per box, just because the numbers don't work out, right? You're going to have maybe a couple hundred people at a box. Not all of those people are going to be members of practice. You need more patients. And so we really see, at least the way that we see it initially, and of course we're going to learn and figure out what works best, is to sort of be independent of the box, but have relationships with multiple boxes in the area. And then not only to be able to serve those boxes and have, you know, open communication between the trainers and the athletes of those boxes, but also to be able to funnel in new patients. So if we're associated with a box, if we're like, oh, this is the medical practice that's in a CrossFit box, you're going to really scare away the people who might really need you the most. And so we feel like being sort of not associated with any one box, we can also then bring in people who maybe have chronic disease or overweight or afraid to exercise, and we can introduce it to them over time in a way that maybe is less intimidating. And then once they're comfortable, we can hand them off to a local CrossFit affiliate or another community that's going to be able to take them the rest of the way.
So Julie and Danny, what do you need? So you're referring out for some of these services, specialty stuff, imaging, obviously pharmacy. What do physicians like you two need to get rolling? I mean, what does that space look like? Is it pretty simple from an actual, room and equipment setup?
That's a great question. It's really simple. I liken it to what a CrossFit box is compared to a Globo gym, right? You could start it in your garage if you wanted. Like a lot of CrossFit boxes started in a very small space in their garage and were very sort of humble, low overhead beginnings. And you can start a direct primary care practice with just a laptop if you want to in your house. And you could start it with telemedicine, or you could start it with home visits, or you could set up a little office somewhere and start there. But it is actually very, you can start it in a very low overhead way and then grow it as you grow your practice.
Yeah. The thing is, like, once you have the electronic medical record, you have the little supplies that you need for primary care, because really what it requires most is kind of your brain and a stethoscope. And then maybe, like, I think there's certain things that you do need, like an EKG machine, just some of the, but I've heard of practices getting started for $5,000, which is
I think
mind blowing.
those are people who really like scrape it together.
But there are, the point being is there are ways to do it, and it's not overly expensive. Like a really reasonable would be like 15, 20 grand to start a practice. I mean, it's not astronomical, not what you typically think. I mean, there's certain CrossFit affiliates that's way more than that to get started. So it's very, very doable, but like I alluded to earlier, it takes a lot of grit, and you kind of be in the dirt for a while, and be willing to not see an income for a couple months.
Which I think speaks back to that. You had mentioned the increasing student debt burden, for physicians coming out. I mean, the challenge of straddling that line when you get out and being able to sustain yourself for long enough to build it up. Like, we totally get that. Are you seeing in PT, we're seeing a lot of innovative DPT programs now that are doing more flipped classroom models and hybrid programs and keeping costs down. Are we seeing medical schools begin to adopt some of these ideas to decrease some of that initial debt burden on their graduates?
So we were lucky. I mean, in our program, we were very lucky because in our med school, actually, there was no tuition. It was basically free tuition for all of the students. It was a small school, but for the sole purpose of they didn't
wait, whoa. Can we? was that no tuition?
No tuition.
Yeah.
Right?
Yeah, no
tuition.
Well, that's doing a hell of a job of getting that cost down.
Yeah, but the sole purpose was because they didn't want, like, when they formed this school, it's still a relatively new school, but they didn't want debt to limit what careers people pursue. They didn't want people to have to feel like they have to pursue a certain specialty just to pay back debt. And partially because the program was geared at developing physician scientists, so they really wanted people to do research, and they didn't want debt to deter people from pursuing that path. We've also seen it. I think there was another school, I don't want to say, it was a school in New York that also just recently made a similar move where I don't know if it's free tuition or like dramatically reduced tuition for all of their students. So I think that there are definitely, there's a move in that direction, because it is kind of ridiculous how much debt people come out with, and how, you don't really start your career until you're like 30. But there's still obviously a lot of work to do.
And there are programs where you can work for like a federally qualified health center. There are programs where you can work for nonprofit for a certain number of years and get your loans forgiven, but nothing in the realm of where you can start paying things back even during medical school, so you can graduate with any reasonable amount of debt. That's unfortunately pretty rare.
Question from Clint, and just one or two more, and then we'll let you all go. What advice would you give to PTs who want to find physicians who are practicing in this model, aside from the CrossFit site? When that CrossFit site came up, you have no idea how pumped we were in this. So anything beyond that.
CrossFit for 10 years.
Yeah, it took so long. But yeah, there are similar finders actually on the DPC Frontier site has a DPC mapper, so you can find direct primary care practices in your area. And the functional medicine site, ifm.org, also has a physician finder. So again, there is some overlap. Like, you might find a direct primary care practice that's not necessarily fitness focused, or, functional medicine that's not necessarily fitness focused, but maybe between the three of those sites, you can find what you're looking for.
But generally speaking, I would say direct primary care doctors are open.
Yeah.
They're not going to be like the ones like pushing pills and be like, if you don't like pills, you're not part of my practice. They'll listen. They're like CrossFitters. It weeds out the really crummy people. Like it's hard to find people who are willing to go the extra mile to take care of people and still be mean. It doesn't make sense. So yeah,
they're much more open-minded for sure.
Awesome. Well, this is wonderful. I'm scanning our group of 40 or 45 that we had on before, and the majority of them own their own practice in some capacity, and I know are just looking, like I said at the beginning, one of the tough parts for us is you get folks who come in direct access because most of our clinics are, many of them are out of network, very similar to what you all are doing, charging, a reasonable fee, but all cash, no insurance. And you get people in this ecosystem, but we are well aware that, we want to stay in our lane and drive fast. There are plenty of things that are beyond our scope. And we're often looking for an MD voice, should I get some imaging? Is there something here that I need to think further about or consult out? So just knowing this is out there and growing is beyond exciting. And I guess I would ask you here at the end, how best ways to keep following everything you two are doing so that as things evolve, we can continue to use these resources. I mean, Pursuing Health podcast, obviously, both of your social medias, anywhere else we should be looking on the regular to stay updated.
Really, the best place to stay updated with us is just if you subscribe, info@pursuinghealth.com, and then if you subscribe to our newsletter, because we put out at least once a month, we kind of give an update on what we're doing, and we will definitely be updating as soon as we have any information about a practice or anything like that on there. But yeah, there's the podcast and the social media.
Yeah.
Sweet. Awesome.
Great question.
Well, team, thank you so much. Like I said, we were all texting back and forth all day. Could not wait to hear.
I love it. We really
We're
appreciate it.
super excited. Yes,
so
thank
cool.
you so much for the opportunity. We had a blast talking with you guys.
Sweet. Well, I'm sure we're going to bug you again in the future, but we'll give you some space for a while and then we'll hound you
Yeah, we
again here
love
in a
that.
few months.
Anytime.
We love that.
Awesome. Thank you again. Have an awesome rest of your night.
Thanks, you too. Talk to you later.
Okay. See ya.